Our first talk is Thrombocytopenia and Clinical Practice. I'd like to invite the speaker, Dr. Unni S. Pillai, Consultant Medical Oncologist in Caritas. Also welcoming the chairpersons, Dr. R.N. Sharma, Senior Most Professor and HOD in Pushpagiri Medical College, and Chairperson, Dr. K. Vijay Kumar, Retired Professor in Kottayam Medical College.
Good morning, everybody. Very happy to be part of this CME on this pleasant morning. And I should congratulate Sadakat for making this very good CME come true. Now, thank you also for permitting me to co-chair with Professor Vijay Kumar. Now, the first talk is, as already said, thrombocytopenia. Thrombocytopenia is a very common problem. The condition spanning from most innocuous and treatable megaloblastic anemia, and at the end of the spectrum you have untreatable, dangerous malignancies presenting as thrombocytopenia. And in between you have got a lot of cause of thrombocytopenia which will, with varying prognosis and treatment aspects. There are problems encountered by physicians, general practitioners as well as specialists. How to go about, we'll definitely have a panoramic approach after the talk. I'll just give the mic to Professor Vijay Kumar for remarks.
We are not wasting the time. Though the title first was clinical approach. Here, Dr. Unni S. Pillai is doing my approach to thrombocytopenia. It may vary from person, doctor to doctor. Okay, then. You can start.
A warm good morning to all the delegates, respected chairpersons, and also I thank Dr. Sadakatullah sir for giving me an opportunity to present. There are only 20 slides, and I'll try to restrict in 20 minutes. And please remain me at 15 minutes. I shall spare 10 minutes for discussion. So when he asked me to present this topic, I requested, please give me some other topic, like anemia or something. I'm fed up presenting this topic. But he insisted me to present this topic only. But during the, preparation time, I also learned a lot of things. So it will be a new insight for me in some of the aspects of thrombocytopenia. So it's clinical approach to thrombocytopenia. I'll tell you how I, treat thrombocytopenia patients, and the outline of talk will be like continue. Our outline of talk will be to first my objective will be to define what is thrombocytopenia. We'll see a little bit of pathophysiology of thrombocytopenia, and we'll discuss some case scenarios. This is how I outline this talk. So, not moving. Okay. So, as you all know, the normal platelet count is 1.5 to 4.5 lakhs per cubic millimeter or microliter. So, anything less than 1.5 we call thrombocytopenia. But on a clinical perspective or from a clinician's perspective, what will be more pragmatic or clinically relevant will be a platelet count of less than 100,000. So now they are going to change the definition, because a platelet count between 1 lakh to 1.5 lakh, if that is stable for at least for next, I'm getting some sound. Can you rectify this? I'm getting some sound from the computer. So, if the blood count is between 100,000 to 150,000 per cubic millimeter, and that is stable, say, for the last 6 months or so, then that is normal for that patient. We need not have to spend much time and effort on that. So, a new definition, or pragmatic or practically relevant definition of thrombocytopenia will be a platelet count of less than 100,000 per microliter. And how do you classify the severity of thrombocytopenia? If you look at it, a platelet count between 70 to 100,000 is okay, because that is not going to produce any major bleed, and you can go ahead and do any procedure if the platelet count is more than 70,000, including neurosurgical procedure. So a platelet count between 70 to 100,000 we are going to call them as a mild thrombocytopenia, and may not be clinically very relevant. When you manage a patient, a platelet count between 70 to say 20,000 is significant, and you may have to adjust the dose of many of these anticoagulants in that range, and this is what we call a moderate thrombocytopenia. And your risk of spontaneous bleed increases when your platelet is less than 20,000. You may get petechiae, cutaneous bleeds, etc. when your platelet count is less than 50,000, but you are unlikely to develop any major bleed when your platelet is about 20,000. So anything less than 20,000 will take it serious thrombocytopenia. And along with that, I'd like to add someone with fever, 20,000 and less is significant, but someone without fever, even a platelet count of 10,000 is absolutely perfectly fine. So this is how we classify the severity of thrombocytopenia. And this is very widely circulated slide picture among all medical fraternity. I took it from the Australian General Physicians website. So if you see the pathophysiology of thrombocytopenia, it could be due to decreased production from the bone marrow, like aplastic anemia, acute leukemia, a malignancy infiltrating the marrow, tuberculosis infiltrating the marrow, chemotherapy, radiotherapy, and so many other drugs. Or it could be due to increased destruction, and the increased destruction is mostly immune. And the most commonly seen are ITPs, drug-induced, HIV, especially in the early phases of HIV, around 10% of patients will have isolated thrombocytopenia, and various other viral infections. And also you can have non-immune destruction, like disseminated intravascular coagulation, TTP, HUS, which are basically life-threatening diseases. And also you can have splenic sequestration in portal hypertension. So this is about the pathophysiology. So when someone comes to me with thrombocytopenia, my first thought will be, is it an isolated thrombocytopenia, or it associated with something else? Is there associated with other features like anemia, other cytopenias, or increase in WBC count? So my differential diagnosis varies. So if it's and you also need to take a very good history and clinical exam. You need to be extremely good physicians to correctly and rightly treat all cases of thrombocytopenia. So it's a jigsaw puzzle, and we need to do a lot of mental work to get a diagnosis and also to go about how to treat these cases. So if it's an isolated thrombocytopenia, meaning the only abnormality is thrombocytopenia, then my first thought will be whether it's a pseudo thrombocytopenia or a true thrombocytopenia. A pseudo thrombocytopenia means the platelet count is actually normal, but because of the anticoagulant, basically EDTA actually changes the glycoprotein, react with the glycoproteins on the surface of the platelet. It causes clumping of the platelets. The platelet count will be normal, but you'll have, on the counter you may get an abnormally low platelet value. It's called a pseudo thrombocytopenia. So this can be avoided by taking the sample in a heparinized tube or a citrated tube, or you can do a simple peripheral smear. And this peripheral blood smear is going to be an important and most important investigative tool when we manage a case of thrombocytopenia. So do that. This is a case of this is a smear. The platelet count came as 20,000. The patient came to me, and this is I think this is but on the smear you can see lot of clumping of platelet. This is the classical picture of what you call pseudo thrombocytopenia. And now you have n number of causes for isolated thrombocytopenia. It could be congenital also. You have many of these autosomal dominant thrombocytopenia, Bernard-Schullier syndrome, so many are there, but we are not venturing into that. Basically, this is for general physicians. I'll be confining myself to the basics of thrombocytopenia. So the most important thing which we need to understand is ITP, or immune thrombocytopenia. You can also have drug-induced thrombocytopenia, viral infection, H. pylori, everything can cause. So this is a real case. The 22-year-old female, otherwise normal, history of some viral infection, flu-like symptoms some few weeks back, is evaluated at some peripheral hospital for cutaneous bleeds, menorrhagia, and on peripheral smear examined, and on hemogram. This is a new way of. This is how we write the hemogram. This is hemoglobin, this is WBC, this is differential, and this is the platelet. So, I'm getting this sound, lot of sound here. So if you could stop the sound on this computer, I'll be very grateful. So, your hemoglobin of 12.4, WBC of 4,500 with relatively normal disease, and the platelet of 13,000. There is clinical examination is absolutely normal except for this cutaneous bleeds, petechiae, purpuras. The viral markers are normal. DCT is normal. USG abdomen is normal. H. pylori we generally do is normal, and ANA is negative. And what is your diagnosis? Please. So what is your diagnosis? This is a classical case of immune thrombocytopenia. So earlier it was idiopathic thrombocytopenia. Now that has changed. It's become immune thrombocytopenia, and we don't use the term purpura. This is only immune thrombocytopenia. And what all investigations you do? We need to do a good peripheral smear, and has to be examined by a qualified person. And that, you are looking at the morphology of RBCs, WBCs, and platelets. You have to look at whether there are blasts. And RBC is also important because in a case of, TTP, what you may get is only helmet cells or destructed RBC. So the peripheral smear was normal except for thrombocytopenia, and probably you may get some large platelets. So an ITP is always a diagnosis of exclusion. There is no, this is the test for ITP and this is the confirmatory test for ITP. This test is not there. So this is purely clinical, and that's the beauty of, general medicine. Purely clinical, and we need to exclude other causes, and can be done with very minimal investigation, which I have listed in the previous slide. And, the next question is, will you do a bone marrow for a case of ITP? Floor open to the audience. Will you do? We need not have to. We need not have to do a bone marrow unless it is in a patient who is above 60 years of age. Because above 60 years of age, another diagnosis will come into the picture, that is MDS, that is myelodysplastic syndrome. And isolated thrombocytopenia might be the first sign of an early MDS. Okay. So otherwise we don't use. And how do we treat? It's very easy to treat. What I do give is pulse DEXA. We do, that is dexamethasone 40 mg for 4 days, every week for 3 weeks. And along with that, then there is 2 recent NEJM articles which says that if you use MMF, that is Celcept, mycophenolate methoctyl, along with DEXA, you are, the patient will stay in remission. The remission is defined as a platelet count of more than 30,000 for more than 6 months. The remission duration and the remission, the percentage of patients who's going for remission will be better. So this is what I generally do. Secondly, we use rituximab. That's an excellent drug. For poor patients, we generally use dapsone. I am from JIPMER. Our professor was Dr. T.K. Datta. He has published the maximum on the use of dapsone as a agent in chronic ITP, and we do get fantastic results with dapsone, 100 mg per day, and 1,000 tablets will cost only 200 rupees. For 1,000 days of treatment, you need to spend only 200 rupees. And will you any takers of splenectomy in the current era? No. Actually, you should not do splenectomy, because in a European registry, what they found is that those who underwent splenectomy for ITP, their median survival is at least 10 years less. You are losing 10 years of your life by simply doing splenectomy. And we have multiple better agents now. You have thrombopoietin analogs like L-thrombopac, romiplastim. We have been extensively used in our OPD. And we have fantastic results. And we have so far 0 death due to ITP. We never transfuse unless there is bleeding. And the point which you need to look into all patients with ITPs, whether there is moist bleeding or not. Moist bleeding means any mucosal bleeding. If you have any mucosal bleeding, hemorrhagic bulla in the mucosa, then that's very serious. We used to give them either IVIG along with steroid, and we try to bring their platelet higher as fast as possible. So that's the take-home message on ITP. I think it's not changing now. Sorry. Now you have a drug-induced thrombocytopenia. Various mechanisms are there. Most common is quinine type. Then you have haptene-induced. You have monoclonal. This drug-induced can be very rapid when you use some drugs like abciximab, which is mostly used in cardiology, and cardiology, professor is there. He'll be able to explain more about that, and those patients will not come to us. Autoantibody induced, with that we usually seen Fiban type and immune complex type. And this was a major problem. And now this is a 65-year-old lady, postmenopausal lady, osteoporotic, had a fall and fracture neck of femur. She was admitted for surgery, and due to high risk of DVT, she was given Clexane or any kind of, for that matter, any kind of heparin. And baseline, her blood parameters were normal. On day 7, and this fracture is on the right side, she complained of severe and excruciating pain on her left leg. On examination, left leg was pale. The toes were going in for, necrosis, ischemia. And there was a necrosis at the site of unfractionated heparin injection site. And the Doppler showed thrombosis of the femoral arteries, and hemogram shows a hemoglobin of 8, which was normal initially 12. WBC is normal and a platelet count of 56,000. And what is your diagnosis? Please, come on. Residents. It's HIT. Okay, HIT is heparin-induced thrombocytopenia. Very classical presentation. Usually your platelet may not go below 50,000. And the classical 40, this is the 40. Very important. This is how classically the patient presents. And the 40 is very important. Thrombocytopenia, usually more, and this is classified. You can go back and refer. This is available in all the textbook. And if your score is more than 4, here the score is 8. If your score is more than 4, you can reasonably conclude that this is HIT. And we need to immediately stop this heparin and have to start on either some of the other newer agents like fondaparinux or rivaroxaban, dabigatran or something like that. So, and this is another very common scenario in our country. By the end of summer vacation, we all will be seeing a spike in fever cases. The 100 or 50 day per OPD will become 150 day per patients per day OPD and 200 patients per day OPD. All of them will come with fever, myalgia, rash, etc. And occasionally, and someday you may see multiple patients, sick patients with thrombocytopenia. And obviously we all know, no one misses diagnosis nowadays. This is a dengue fever. Now, this is another patient, a 35-year-old patient. I hope, how much time has left to me? Time over. So, it's a 35-year-old patient after a road traffic accident, multiple blunt injuries, fractures, and sick patient admitted in ICU, progressively became sick and intubated. Chest X-ray showing a multiple lung patches in sepsis and not probably responding to many of our antibiotics. And blood culture is showing growing E. coli. Okay? And next day, immediately on 12 or 24 hours after intubation, you are getting a call from the ICU saying that, doctor, patient is bleeding from the nose, there is hematuria, bleeding from gums, patient is bleeding from everywhere. This can also happen in an acute promyelocytic leukemia patient. We have many patients coming on Saturday, that's a Saturday evening syndrome. We call our PGC dose. They all come Saturday afternoon when we are about to go home. They'll come sick with bleeding. And your WBC is 7. This is for this patient with sepsis. WBC count is high, probably due to sepsis. And you can also have low WBC in that scenario because the bone marrow will be fatigued with the cytokine storm, and the platelet is also low. Yeah, this is important. And in this case, this is how we differentiate between the next case and this case. This PT, APTT is elevated. Fibrin degradation product is high and your fibrinogen is low. And what is the diagnosis? This is a DIC. And this is a life-threatening. These are all life-threatening situations. Now you have another patient, also my patient, a 56-year-old metastatic carcinoma breast on palliative chemotherapy with the gemcitabine. So gemcitabine came on day 7, day 8 with jaundice, anemia, bleeding, seizure, and anuria. What is your diagnosis? It's a classical case of HUS or TTP, thrombotic thrombocytopenia purpura, because seizure is also there. So when HUS, you may not get the neurological findings. In TTP, you'll get the neurological finding also. These are the lab parameters. You have anemia, you have severe thrombocytopenia. Your creatinine is very high. You have a lot of bilirubin is high. This might be due to the liver metastasis also. And here your DCT is negative and PT APTT will be normal, provided the liver function is normal. Okay, liver is normally. And what you get is, this is how you differentiate between the two, the DIC and TTP. And haptoglobulin is low. This is a classical case of TTP and urgently requires exchange transfusion. Okay. And peripheral smear is the wonderful and the most important investigation for all of us, especially in hematology. We all should know the basics of peripheral smear, how to make a peripheral smear, how to stain it, and how to look under the microscope, at least under oil immersion. So this is, here you are seeing probably no platelets. You are seeing lot of fragmented, this is the helmet cell. There are a lot of fragmented RBCs, and this is a classical case of TTP. And also you have another patient, you are coming to you with a WBC count of 1 lakh, platelet of 10,000 and hemoglobin of 7. Probably you may suspect leukemia, and this is the peripheral smear exam. You are seeing blast. And also we have so many patients. Recently also we had a patient, a 25-year-old man in a hostel, wanted to reduce his weight, so was dieting for a long time, and was getting only vegetarian food at hostel. Was because he was studying in a staying at a hostel associated with an ashram. And he came with a hemoglobin of 4, platelet of 12,000 and WBC count of 1,500. LDH was 3,500 or something. And the peripheral smear will show you this. What is this? This is a hypersegmented neutrophils, and this is vitamin B12 deficiency. So, and now the take-home message, what are the red flags in thrombocytopenia? Any mucosa bleeding, hemorrhagic bullae are very serious, and they are at high risk of intracranial bleed or visceral bleed. They need to be urgently treated. And in that scenario, you can give platelet transfusion even in ITP. Second, any blast in peripheral smear or any abnormal cells like malignant cells in peripheral smear is a red flag. A thrombocytopenia in a person above the age of 70 years need to be investigated with caution, because that may be the first sign of an MDS or even the first sign of an acute leukemia. And we are going to do a marrow examination that patient. And on peripheral smear, if you are seeing dysplastic cells, associated features which we have discussed now, fragmented cells, hypersegmented neutrophils is there. It's very easy to treat. You give vitamin B12, you give transfusion. You give WBCs, you give platelets, not WBC. You give platelets, you give transfusion. We might be able to save that patient. This is our emergencies. We have patients with megaloblastic anemia came with circulatory failure, congestive cardiac failure. We have many patients comes with the diagnosis of this, all because of pancytopenia. They all suspected cancer, came to us. When we elicited history, they all say that I am vegetarian for 6 years, 7 years, and the diagnosis is then and there clinched. And all HIT is an emergency which you need to treat urgently. TTP, HUS are emergencies. And now, regarding some practical aspects, When will you do platelet transfusion? I will not do platelet transfusion for any patients with platelet count of more than 20,000. This is a statement. And I will be very angry with my PGs if they are giving platelet about 20,000, because they are precious and has to be reserved for needy patients. Unless there is a major bleed. The excluding, cutaneous bleed we are not going to do, but if there is hemorrhagic wet bleeding or major bleeding, we do that. Anyone with a fever and platelet of less than 20,000, we do transfuse. Anyone without fever, my cutoff is 10,000, but you also wait up to 5,000. What is important is not the platelet count. It's also called, if you have a facility to look into the immature platelet fraction, that is important. If you have a very high immature platelet fraction, that indicate that there is immune destruction, but the marrow is trying to compensate for that destruction. We need not have to worry much. Those patients may not bleed much. And also this can be done in ITP also. Very good investigation in ITP also. So up to 5,000 you can wait, but generally, in today's scenario, we give up by 10,000 we give transfusion. For putting a central line, there are some spelling mistake. I don't know how come that atheist channel came over there. So at least that's not atheist. It's at least a platelet of 20,000 should be there. For elective, I'm sorry for that spelling mistake. For elective surgeries, a minimum platelet count should be 50,000. Elective surgery, including hip replacement, liver transplantation, kidney transplantations, your hernia repair, cesarean, whatever. If you have a platelet count of 50,000, you are absolutely safe. You are not going to get a high bleed. And for elective lumbar puncture also 50,000 is okay. But if you are going for any neurosurgical procedure or that's not vitriol, it's all autocorrect. I'm so sorry I didn't read this. Retinovitreal surgery, it should be at least 75,000 or more. With that, I thank you all for your patient listening. Thank you. And if time permits, I can take some questions.
You have all finished almost in time, but everybody should be, especially physicians, should be well aware of the red flags he had shown. And also, there may be any questions, you can ask questions. The government directive is to transfuse platelet only if the count goes below 10,000.
Yes.
That was the government order.
Yes.
Once, a few years back, there was a hue and cry. Everybody, when the platelet falls from 50,000 to 45,000,
not required.
They were all running around for platelet transfusion, demanding to the doctor, you give platelet. Then that time, Kerala government had directed. Only less than 10,000 is indication.
Yes.
Right.
Less than 20,000, suppose you have an acute leukemia patient in sepsis, ventilator, and with high fever running, it is 20,000. Otherwise, 10,000. And ITP, we don't transfuse. Even with 5,000, even with 1,000, I have not transfused. Unless there is a red flag like mucosal bleeding, we do transfuse. Otherwise, even with thousands, they won't bleed. They won't bleed. And acute thrombocytopenia patients bleed more rapidly than chronic thrombocytopenia patients.
So rapid fall is also important. Say a person,
yes.
Rapid fall in
Rapid fall
platelet,
is
you
also
should be
important.
skeptical.
And they say that in TTP you should not transfuse. But that is also a caveat, is that if you have a life-threatening bleed in that situation, you can transfuse in TTP also. But, rather than transfusing in TTP, your aim should be to do an exchange transfusion and remove the antibodies.
Any more from the audience? Now, just one point, talking about pseudothrombocytopenia. What are the clues? One, you change the thing from EDTA to the heparin. Another clue is the platelet satellitism. If you look at the peripheral smear, the platelets are clumped around the WBC.
Yes.
The classical NEGM smear is there. So we also see that. That's also important. Then conditions where you have thrombocytopenia and thrombosis. That can you just highlight?
One is this HIT.
Syndrome.
HIT is another one. That is the only thing which I can immediately remember and tell, which we mostly see. It can also happen in acute promyelocytic leukemia. It can be there. Someone who is on L-asparaginase on ALL therapy, they can have present with thrombosis and thrombocytopenia. This is what I have seen in my practice. Not come across with any of those other, No, because platelet surface does not contain any, blood group antigens. You can transfuse any group, and why we insist on group is that sometimes this blood will be, platelet will be contaminated with a very mild quantity of RBCs. If you are having very good blood bank, and if they can give, minimize the contamination, you can transfuse. We are not giving group-specific platelet to anyone. When I request for platelet, I write any group is okay. But the blood bank shall try to give us the same group whenever possible. If that is not there, I do accept any group. But when we make SDP, and all, the RBC contamination is practically zero. There won't be any RBCs in SDPs. So any group is fine. Need not be group specific.
When a platelet transfusion material is transferred to some other place, from one hospital to blood bank to another hospital, is there anything called a platelet shaker? Is it
when they keep in the blood bank, they keep it in that shaker. But what we generally do is that we quickly get it transfused. That is what we do. There is nothing like a shaker, or we need not have to shake it while transfusing. That is not required.
Now, what about how much platelet will be elevated after one unit?
That depends upon the quality of the product, and also when was the product collected. Ideally, we have a transplant going on now. We have admitted a transplant. I'll be making platelet tomorrow. I'll be making SDP tomorrow, and I'm expecting platelet count to come down tomorrow or day after tomorrow, and I'll be transfusing immediately. So the quality of platelet will be better if you do that. Usually when we give an SDP, we are getting something like 30,000 per cubic millimeter increase in platelet. So if you wanted to do that, to make it say 10,000 to 50,000 or so, then we may have to give you 2 SDPs. When you use a pooled RDPs, which was very common some time back, they used to pool RDPs, make it into one bag, and then they used to give 4 or 5 RDPs. They pool, and then that will increase platelet by 10,000. So usually when you give 4 or 5 RDPs, platelet count will get increased by around 10,000 per cubic millimeter. That also depends upon the blood volume of the patient. That's different for pediatric patients and different for adult patients. Also varies depending on weight and all.
Thank you, Dr. Unni. We will wind up this session. If there are any other doubts, you can ask personally to him. Thank you.
Nothing. Thank you. Thank you so much.
Thank you. Inviting Dr. R.N. Sharma to present a memento to Dr. Unni S. Pillai. I'd also like to invite Dr. Keshavan to present mementos to Dr. R.N. Sharma and Dr. K. Vijaykumar.